Good afternoon, everyone. I'd like to get started here. Welcome to the Clinical Trials Methodology course webinar series. Today's webinar is on reflections on the CTMC and years later. Before I introduce our presenters, I'd like to remind you that if you do have a question, please use the chat box to the right of your screen, or you can simply unmute yourself. Also, at the end of the webinar today, if you would just take a moment to evaluate the webinar, and I will provide the link at the end of the presentation. So now I'd like to introduce our presenters. First off, we have Dr. Pirio Richardson. She is an Associate Professor of Neurology at the University of New Mexico and directs the Parkinson's disease program there, as well as at the New Mexico VA healthcare system. She has an active research program aimed at non-invasively altering plasticity in the brain to improve symptoms and quality of life in patients with movement disorders, with multiple grants, publications, abstracts, and presentations. She is medical advisor to the New Mexico Parkinson's Disease Coalition. Next, we have Dr. Sutherland. He is an associate professor of neurology and public health sciences at the University of Virginia. He completed neurology residency and vascular neurology fellowship at the University of Virginia, where he also obtained a master's of science in clinical research. He is the past recipient of an early career award from the American Heart Association, American Stroke Association National Clinical Research Program, and a 2014 participant in the CTMC. He serves as PI or co-I for numerous stroke clinical trials, and his primary research interests focus on innovative methods of pre-hospital stroke care, novel applications of telestroke systems, and gene by environment associations in non-atherosclerotic vasculopathies such as cervical artery dissection and fibromuscular dysplasia. And last but not least is Dr. Kamel, who attended college at Harvard and medical school at Columbia and trained as a neurology resident and neurocritical care fellow at UCSF. He is the chief of the Division of Neurocritical Care and the director of the Clinical and Translational Neuroscience Unit at Weill Cornell Medicine. Dr. Kamel's research focuses on stroke prevention in patients with atrial disease. He is a co-PI and protocol lead for the NIH-funded Arcadia trial, which is testing antithrombotic strategies in patients with cryptogenic stroke and atrial cardiopathy. He is also the PI of an NIH-funded observational study of racial differences in atrial cardiopathy and their link with disparities in stroke risk. Dr. Kamel is the recipient of the Pesson Prize for the American Academy of Neurology and the Seekert Award for the American Heart Association. He serves as the deputy editor of JAMA Neurology. So a big thank you to all of our presenters today. We're going to have Dr. Pirio Richardson start off first. Sarah, you can take it away.
Okay, thanks very much. Can you hear me okay?
Yes, perfect. Thanks.
All right. I'm going to go ahead and share my screen and just go through a few slides. I'm going to focus on the project that I brought to the Clinical Trials Methodology course and just point out a few things that I learned through the course and how that actually even impacted me yesterday. So I'll give you those examples. I'm going to go ahead and share my screen here. So I hope what you're seeing is a image from a publication several years ago of a very small pilot trial that we did to look at patients with cervical dystonia, so an abnormal posturing of the neck, for which we typically use botulinum toxin injections to treat, but has side effects, doesn't last for the whole therapeutic time period, and doesn't help all patients with cervical dystonia. So we attempted to use non-invasive neurostimulation to look at several places in the brain, and you can see the colored arrows on the scalp representation showing different stimulation sites. And then let me show you, I hope what you're seeing now is a graph of the results of that trial. I'm just going to draw your attention to the red line and the blue line. So along the y-axis is the severity of cervical dystonia symptoms, and the higher the score, the worse the symptoms are. And what we looked at was over the last month of botulinum toxin treatment, where patients are typically getting worse, and that's the red line, where their twister score is getting worse over time. We looked at our patients who had our intervention, and their mean score is represented by the blue line, and you can see that they actually got better over that time period when normally they would be getting worse. So we were very excited that we were able to show some therapeutic benefit. So I brought this idea to the clinical trials methodology course to more widely examine this. And I remember giving my first elevator presentation to Chris Coffey, who was one of the mentors in my group. And I practiced my talk quite a few times, and I had it under, I think, 3 minutes. And at the end, there was a little bit of silence, and then Chris got on and said, "I wouldn't do that if I were you." So that was my introduction to the clinical trials methodology course. But we pushed on and worked on a protocol to develop a multi-site clinical trial to both examine different sites of stimulation as well as different frequencies in a very efficient manner during a botulinum toxin treatment cycle. So this went into the exploratory clinical trials mechanism at NIH, and the first review, there were some encouraging remarks but needed to be revised, and I went through and revised it again. And that application, again, the scores were improved, but the one thing that I didn't realize in all of this, we had really focused in the methodology course on the clinical trial methodology, and that part of the grant was very, very strong and had been, again, vetted by many people, including Chris Coffey, several times. But what I had neglected to spend time thinking about or paying attention to was how well I was communicating the need for doing something like this. And this is especially difficult in a clinical space where there is a treatment modality that's FDA approved. And so most people assume that this therapy does adequately treat the patients in the way that they need to be treated. And so that's actually been, I had to sort of take a step back from this project and re-look at how well have we shown what the need was. And so this was one of the first outcomes that came out of me participating in this course is I had to go back and rethink how well we were presenting the need. So this next slide shows work that we did looking at a database or natural history study of patients with dystonia worldwide. This is over 2,000 patients with dystonia. And what we were looking at was to just find out in the real world how many people were using the therapies that were recommended for dystonia. The only FDA-approved therapy is what you see in the dark blue and the light blue lines. So that's Botox or botulinum toxin therapies. There are oral medications that are recommended but not FDA approved for the treatment of dystonia, and you can see that there are some folks using it, but not very many. And then the red bar shows you the number of folks this was a cross-sectional study across the world, who were not using any kind of therapy for the treatment of their dystonia. This highlighted two big things for us. One is we could show there was a need, there was a gap. There's at least a quarter of people at any given time not using therapies for their symptom management. And it also showed us that the reality is that many people are using botulinum toxin, and so if we're going to try to find a therapy that's even better, we're going to have to take this into account and pay attention to this on how we can actually measure outcomes in the setting of botulinum toxin use. Skip over that one. That's also just, again, a graphical representation showing you that across the world, just looking at the red dots, there are patients who are not using any therapy for this problem. So I'm going to lead into where I am now. So what this has actually done is changed my project to a way of looking at what we call this yo-yo phenomenon. So if you look in the box A, this is what we hope happens in an ideal therapeutic response. Patients are injected, efficacy increases over the first couple months of their injection cycle, and then benefit wanes. Hopefully not back to their baseline, but we inject at approximately 3 months, and again, they have improvement or efficacy, and then a wane over time. And that would be in the ideal setting. We of course know, and what's shown in B and C and D are other options or alternative treatment cycle efficacy that we could see, where there could be a very short duration of therapy and patients are actually waiting for their next injection. There can be dose failures, and over time the benefit actually may wane. And this is actually a reality. There's 2 clinical trials going on right now in dystonia patients that were funded and approved, but no one knows how to deal with the outcome measures because of these issues. So just last month, we put in as part of a large international consortium of dystonia researchers, we just put in I'm the PI on this project where we're actually going to measure this and look at what the reality is over a botulinum treatment cycle using patient-reported outcome measures, looking at standardized clinical measures, and we also have some objective measures that we're looking at so that we can get a good idea of what the variance is in response to botulinum toxin over multiple cycles. Because all of us know that there's a gap in therapy and we have to be able to adequately measure it. So, my project is, I've of course gone on and done a bunch of other things, but the things relevant to what I brought to the clinical trials methodology course is really change focus. Those principles that I learned in there certainly have persisted in terms of the clinical trial methodology, but it did make me have to take a step back to realize that in order to be successful in the funding, we really had to show that there was a gap or treatment need. And so the last thing that I'll leave before we move on to the other speakers is what I had to do yesterday, which was a pitch, an elevator speech in front of the higher education department. So I had to talk to I had to present to the Secretary of Higher Education about a proposal we have for funding of a comprehensive movement disorder center. There were 3 groups. I'm happy to say there were 3 groups that went before me who clearly had not had the benefit of Chris Coffey telling them that their project was not going to go on, because I really was able to hone that skill both through the clinical trials methodology course and then the other opportunities that's afforded at annual meetings and other things to really have a very successful presentation yesterday. So it was a wonderful experience for me. I think I'll leave you there. I hope you get a little bit of an idea of where I started, where we are, at least in terms of the dystonia work, and I'll leave it there.
Thank you, Sarah. I appreciate that. Are there any questions for Sarah right now? Or okay, let's move on to Dr. Sutherland.
All right. Can everyone hear me? Hopefully, okay. I'm gonna try the same thing as Sarah and try to share my screen here. Let's see if this works. Hopefully everyone can see this, these slides coming through. Tell me if you cannot. So basically, thank you to Will, to Joy, the folks at CTMC for having me back to do a webinar today. It is always fun to come back and support the clinical trials methodology course. And tell you a little bit about my experience, which is actually the same year, I think the original year that Sarah participated, and then what I'm doing now from all that I've benefited from by participating in the course. I have a few disclosures, mainly research support, and then some non-remunerative intellectual property related to the trials and studies. I'm not going to talk too much about my original protocol or my research. I think it's more salient to tell you about the process as opposed to the nuts and bolts of my trial. But just to give you some background, because it speaks to some of the challenges I had initially and how the course helped me, I was attempting to do a trial of mobile telemedicine in ambulances for patients with acute stroke during transport, and use a low-cost portable telemedicine system that we developed here in our Center for Telehealth, with the overall goals of trying to improve the accuracy of our pre-hospital stroke diagnosis, to help with appropriate triage, particularly for patients now with large vessel occlusion strokes, and then hopefully ultimately to reduce stroke onset to treatment times with TPA and endovascular therapy, and then potentially as a tool to facilitate other forms of pre-hospital stroke research as a diagnostic tool. The reason that this was challenging is because the goal of the trial was to enroll patients in the pre-hospital setting. And for any of those who are listening that have participated in pre-hospital stroke trials, Will and others in the emergency medicine field, this is a challenging proposition, both working with EMS providers, but also with ethical consideration and institutional review boards. So, so around that time, this was 2013 that we first sort of developed this idea, and we hit the ground running, submitted some grants, got some funding from my institution, got some funding from some state EMS agencies, and even received a foundation grant to move forward, and then tried to hit the big leagues at the gate with an NIH grant that was not funded ultimately. And at this point, even though we'd had some early success, this was a bit deflating because I wasn't sure what direction to go next. And one of the things that has allowed me to be successful is good mentorship over time. And so then I turned to my mentor, who at that time was Brad Worrell, who is our Vice Chair of Research here at UVA. And serendipitously around this time, I sent an email, and I still have the email here, from April of 2014, inquiring about this new clinical trials methodology course that previously was called the VAIL course and now is going to be in Iowa City, sponsored by University of Michigan and University of Iowa. And I thought initially, I said, wow, from VAIL to Iowa City, this is perfect transition. So, but it sounded intriguing nonetheless, and Brad encouraged me to apply. So. To Iowa, I went in 2014. So, and so at the course, without going into the nuts and bolts of my specific trial, I'll tell you a few of the things that were very essential to me developing my protocol. One, I think that talking amongst small groups and mentors and other seasoned investigators, I was able to better refine my hypothesis. I was asking the wrong question, and as many of you know, or hopefully are learning, that's the first step in leading to a successful research study. I also was able to develop my specific aims in a less ambitious way. I was trying to bite off too much, I believe, for the state of the trial as I was hoping to conduct it. And by virtue of that, was able to sort of narrow down on an early phase feasibility trial rather than something more ambitious. Working in small group session and with mentors at the CTMC, I was able to better refine the primary and secondary outcomes for my study, and specifically, rather than looking at actual patient outcomes at this stage, we decided to use an intermediate outcome or surrogate outcome with inter-rater agreement of the NIH stroke scale, whether or not we could basically use this mobile telemedicine device to gain an accurate stroke diagnosis during ambulance transport. And then I think above all, what I benefited from greatly, particularly in small group sessions, was consideration of statistical analysis and specifically sample size. And so I was doing an unconventional trial, looking at in an unconventional setting, and really trying to think, okay, how could I come up with a sample size analysis that would be palatable to funding mechanisms going forward? And that's where thinking through that and working with the statisticians at the course, Chris and others, was super helpful. And then the other piece that I think I benefited from greatly at the course and still benefit from today in this area of research were the ethical considerations for doing pre-hospital research. There were experts speaking at the course that continue to participate now, who were leading investigators in some of the other pre-hospital stroke trials that have been conducted in neurology, such as for status epilepticus, the FAST-MAG trial. In stroke, I got to interact with folks like Jeff Saver and the team there at University of Michigan, who have been leaders in pre-hospital stroke trials. And really consider, how do you consent a patient in an ambulance? How do you propose doing an exception from informed consent, or do you try to get exemption from informed consent? These were concepts that I'd given very little thought to leading up to this point, but that I was able to nail down, at least moving forward with a feasibility trial coming out of the course. Also give a shout out to Catherine Challoner, who was one of the statisticians in my course, and she really helped me develop my sample size calculation. Unfortunately passed away shortly after the course in that time frame, and so just a note in honor and memory of her for her help. So the output. So with all of that, I actually left the course in much better state than when I entered. I was able to follow up and return a full protocol to the group for review, continue to receive feedback, and ultimately has led to a fair bit of productivity to help me, namely a number of manuscripts from this protocol. I was able to actually go forward and conduct a phase 2 feasibility trial of this mobile telemedicine system during ambulance transport. We enrolled roughly 50 patients or so. And that was successful in helping establish the feasibility of using this low-cost ambulance-based telemedicine system. It supported research for multiple students and trainees using, again, the same protocol backbone and scholarships for several clinical research assistants and students who were working with me, led to several national presentations. I was able to develop an NIH StrokeNet proposal based on the trial, and then really the main thing that helped push me over the edge was to take the protocol and put it into a successful grant submission from the Health Resources and Services Administration that ultimately funded and supported conduction of this phase 2 feasibility trial. And I think even more than that, the skills that I learned, the experience that I had from conducting this early phase trial, the mentorship that I received have allowed me over these last few years to further evolve into an independent investigator in my own right, now serving as site PI for some multi-center trials, including the one that Dr. Kamel will tell you about, the Arcadia trial, where I'm our local site PI. And then it's also helped me further my own specific research interests, particularly in pre-hospital stroke care and novel uses of telestroke, with several more grants that I've been able to receive, one industry-sponsored trial and another from another foundational grant to do some work in this area, all essentially stemming from that backbone of this early phase clinical trial that I developed at the Clinical Trials Methodology course. And then probably for all of us in academics, this was essential to me getting promoted. So a big thank you to the CTMC, which is what we all want if we're going to continue to have a job in academics. So life after the Clinical Trials Methodology course would encourage all those who participate to continue working on the protocol even after the course. If you're able to participate, this is essential. It's like a sculpting. It constantly has to be chiseled and refined and adjusted, sort of as Sarah shared with her own experience. And this has been my experiences as well. It's not something that needs to be put away. It's constantly under the development process. I really enjoyed the mock study section that forced me to answer a number of my limitations. And then the extended mentorship I received from the course. I've been able to interact with Will Moyer and Lori Gutman, who are two of my mentors, even over these several years. And even now, I will ping them for questions and advice along the way. And then I think it's really important to continue to come back and support the course through gatherings such as at the AAN and such as this, and keep the momentum going. Lastly, I'll just sort of leave with a few things that I think are pitfalls to success. For all of us, I think we are subject to time management issues with our many challenging requirements, clinical challenges, if you're in the clinical realm, and others. Death by 1,000 emails, I think everyone can relate to that. The abstract to publication ratio, you want to be as close to 1 as possible, which is a piece of advice that one of my mentors gave me. And then not having a good core mentor, even as you get along in your career, it's important to have that mentorship. And then the imposter syndrome, not thinking that you can be successful, not thinking that your grants will be funded, and limiting your productivity. And then ultimately just plain old inertia, not moving forward. And sort of the old do or do not, there is no trial. And then an homage to one of my former mentors, last slide. This was Clark Haley, who used to be a director and helped develop the Vail course. He received a national lifetime award from the American Heart Association and big proponent of clinical trials. And basically, I love this quote that while there's a role for patient experience data, novel statistics, and observational research in a variety of circumstances, there's really no substitute for a well-executed, randomized, concurrently controlled clinical trial. So I'll leave everyone with that. Many people to thank, especially the course and the directors of the course, and happy to answer any additional questions. Thank you.
Thank you, Andy. That was great. Any questions at this point? Okay, we'll move on to our last presenter, Dr. Kamel.
Hi, everyone. Can everyone hear me okay?
Yes.
Oh, great. Okay. So I don't actually have slides. I thought I would just make this a little more informal and just chat about a little bit about my background and the sort of the run-up period to the clinical trials course for me, and then what happened with my project and what I've been doing ever since then, and leave with a few tips from my experience. So I trained, I did my neurology residency, my neurocritical care fellowship at UCSF, and I went into residency. I didn't, have a sort of preconceived interest in research, but I got into research during my second year of residency. They had a pilot program where they gave us 6 months of protected time. We basically were able to pool our elective time all together in one 6-month block, free of call. And so I sort of jumped on that, and I got involved in research and found a great mentor, Clay Johnston, who was there at the time. And I really got into research, and I found it very interesting and fun. So I did a little bit more work as a resident and continued to do some research as a fellow. And then I joined the Cornell faculty in 2011, and it was sort of a Hail Mary. I was trying to get back to New York, and I managed to convince the chair at the time, the interim chair, Matt Fink, who's now the permanent chair. I told them they weren't really looking for someone clinical, but they wanted, I convinced them I would just come and help out clinically however they needed it. And I would spend most of my time doing some research, and we would try to get some grants. And they said, sure, fine, give it a try. We'll take you on for a couple of years and see what happens. So I came in and, had to find mentors from scratch at Cornell. And I just kind of started reaching out to a lot of people there, the cardiologists and folks at Columbia, where I'd gone to med school. And I managed to put together a good mentoring team. And I think that's one really, really key factor in this that you all should be thinking about, is trying to find good mentors who know how to succeed at research and are willing to invest in you and help you out. So that I got lucky there a second time, first with Clay at UCSF and then with my mentoring team at Cornell. And I started to kind of continue to work on some of the stuff I'd done as a resident. I was interested in atrial fibrillation and stroke, and started, to develop some ideas about atrial dysfunction, even in people who didn't have AFib, and using that. Based on that idea, I applied for an HA award, and I managed to get that. And then a year later, I got a K23 award on a second submission, so I had to resubmit. So I think the mentoring team was really key there to help me get those early grants, and that allowed me to continue to have protected time. So the K award started in 2013, and as part of that, I proposed to do the clinical trials methodology course, and I was super excited about it. And I had it planned for the summer of 2015, and building up to that summer, some of my mentors and collaborators, we had started to talk about a clinical trial, and we actually got good feedback from NIH, from the newly formed StrokeNet network. So we started to put this trial together in the fall of 2014 and the spring of 2015. And actually, by the time I was starting my clinical trials course that summer, like the Arcadia, we'd already submitted the Arcadia trial grant application, and we had a very rudimentary protocol. So I'd been sort of planning this whole time to come in and use the clinical trial methodology course to get feedback on this proposal, but just because of timing, the trial was already done. And so speaking to Bill and Lori and Jordan Elm, who were my mentors for the course, they were like, well, this is not going to help you as much if you already have they encouraged me to think of a different project, which I did that spring. I put together a proposal based on something else that I've been interested in a while, which is colchicine for stroke prevention. There's a lot of sort of intriguing data coming out from the cardiology literature about colchicine maybe preventing coronary events due to, I don't know, anti-inflammatory properties or some other mechanism. So I put together like a small-scale pilot trial proposal for that summer, for that course. It was really fun doing it. I was doing it totally on my own until I got to Ann Arbor and got a lot of useful feedback. And so the course was awesome. I really enjoyed it. I feel like I learned a lot about clinical trial design, about some of the statistical approaches involved. And as Andy was pointing out, the networking is great because, you meet really cool, interesting people. I remember meeting Brett Casella, meeting Jordan Elm, who then we're working on something related that I'll tell you about in a second. So I think the networking was really great, and you learn a lot, and you also learn from your peers. So I really enjoyed the project. But since then, I have to say the colchicine project didn't really go anywhere just because Arcadia became this big beast that's occupied a lot of my time. I would love to get back to that colchicine story at some point, but I'm afraid that I think by the time I do, it'll probably have progressed. I think it's a neat area. So I guess one thing for me as advice is that you can learn a lot from this course, even if your specific project doesn't end up playing out the way that you thought. It was a very helpful exercise for me, and a lot of what I learned during the course, I was able to apply to other projects. So that's been sort of my experience. And since the course, Arcadia, we applied that summer. We had to resubmit in the spring of 2016. It got approved at the end of 2016, early 2017. We got our funding started in 2017, and we're now about 10% through enrollment. And there's 4 of us co-PIs, and we're working through the StrokeNet infrastructure. And it's been a lot of work. It's been pretty stressful, but it's also a lot of fun. And so, I've really enjoyed working with clinical trials. I do think it's a great part of a career. And actually, I ended up working with Jordan Elm, who I met through this clinical trials methodology course, on a different trial proposal that was really the brainchild of Kevin Sheff at Yale, who is an old friend. And it looks like that might get approved too. We sort of submitted that. So, I've somehow worked my way into doing a lot of clinical trials. I'm really enjoying it. I'm still trying to continue to do some observational studies too, but doing clinical trials is really rewarding. I'm sure it'll be even more rewarding when one of these trials actually finishes. But even just the process of going through the steps of getting funding and thinking about how to design the protocol and working with your team, it's such a large scale challenge that it's really fun. So that's my story and of my background and how the clinical trials methodology course influenced where I've gone since. My sort of closing thoughts for everyone is, I think tips for success in clinical research in general, not necessarily just even clinical trials, is I think the number one key is just to believe that you can do it. People, I think that there's some magic to this and that it's safe for a select group of people. It's really, I think, wanting to do it, and if you really want to do it, you can do it. You just keep persisting. You should be politely persistent, collaborate, try to find the right mentors, and I think that's really 90% of the secret. And the other keys are mentorship. So you want to surround yourself with people who are going to help you, who are generous, who want to see you succeed, and then just be collaborative. Just form relationships and form networks. Because I think it's a big part of the secret, especially with trials. It's very hard this is not a solo act. And then earlier in your career, I think it's also just important to be able to have some protected time where you can sit and think and read journals, read a lot of things, try to become an expert in some topic or topics, and then read the best studies. You'll learn a lot about the methods and how you should approach your own studies from reading. So I think that protected time early on is really key. So that's it. That's my story.
Thank you so much to all three of our presenters. Some great information and experiences shared. Does anyone have any questions or comments? Or Will, do you want to say anything?
I mean, I almost always have something to say.
I know.
So I think if people have questions, you can you should be able to unmute yourselves or put something in the chat box and we can answer them. I just really want to thank these three for, spending a little time to chat with you, and then we'll be memorializing this on our online webinar series as well. I do always remember Sarah's story about Chris, and we've wanted to go back and look through the video archives, like from some of our sessions, to say like great moments in CTMC history. Like, and we can I can just, from being in many conversations with Chris, I can just sort of exactly see his sort of expression of like, well, you could do that if you want, but that's not what I would do. And yeah, like it's almost like we need a session on faculty impressions. But I think that some of the key things that I was hearing from these three, who I think people at any stage of their career could learn a lot from their energy, their persistence, and their thoughtfulness. I think Hooman, when he was talking about recently this having some time to think, that's really hard, right? But that's really important. If you don't allow for yourself to have some time to think and work through problems, you're going to be, sort of, and that I think kind of fills into Andy's question of death by 1,000 emails. If you're always trying to get to that email, or if your email inbox is, you got one more little thing in there, you don't get to those times to create something that potentially could help patients. And that's, why we have research as part of our careers, is to ensure that we can dedicate some of our cognitive energy, some of our talents, and some of our time towards producing things. But a lot of times it's quite aspirational. You're starting out and I need to get the resources to do a research study that I can learn from. And I think sometimes the things that we plan in the CTMC go forward, and sometimes we learn about the other things we should be planning and spending our time on. And I think figuring out how to allocate your time, having some diversification in that I'm planning this clinical trial, but the right thing comes along in terms of a collaborative group, Andy being a site PI in Arcadia, I was a site PI in the Clearer study that was an early, a thrombolytic study that is a precursor to the MOST study that's about to kick off in StrokeNet, or is kicking off. And that was a great experience in terms of learning more. But in terms of the planning and the thinking about everything that goes into designing something, it often brings you back to what Sarah found, was that the performance of the outcome measure is something, with the standard treatment with Botox, is something that's a little, it's complicated to even deal with that. And if you can't, if you're working with other scientists and statisticians, really understanding how that outcome measure is performing may be where you get. So I think sometimes some of the trainees this year and in past years, it feels like we've gone back and forth in their small group sessions, and we've just continued to go back to the outcome measure. But sometimes that's because, that's where you need to look, in that the outcome measure is, you need more underlying scientific data behind the outcome measure so that you can better reflect what's going on with people. So I think Sarah has spent a bit of time really going into that in depth, and I think has learned some exciting things. And I just think it's cool, like the twister plots. Those have always been cool, just because it seems great. So, all right, I think those are my sort of additional reflections. I don't know if anybody else has any questions for our panel, or if I brought up any other brilliant ideas.
Hi, this is Kamel Patel. I'm one of the CTMC trainees. Thanks to the three of you for sharing your experiences. I was wondering, if you had prior clinical trial experience, say working on other people's trials before you started designing and planning your own, and what that experience was like, and if you wish if there was something that could have been more valuable. I think for a lot of us, we're planning our first trial ever, and we're trying to kind of pull on some past experiences. And I was wondering what were your thoughts on getting more kind of real world experience before jumping into your own trial?
Yeah, Mehul, I'll comment briefly. This is Andy. Hopefully everybody can see and hear me. I think I did benefit from sort of being a junior investigator on a number of trials here at my institution. I also benefited from having a couple of seasoned clinical trialists in my division, and participating at the level of seeing how they developed trials from the ground up, how they developed their protocol, and just taking it from a concept to enrolling your first patient. Obviously, based on the presentation I gave, I had a lot to learn, still have a lot to learn, but I knew enough to at least be able to speak the language. And then having some master's level coursework in clinical trials design and so forth, I felt like that I was entering into a foreign country, but I at least could order dinner, I guess. And but I think that there's no substitute for starting with an idea yourself and really spending that time, as Will mentioned, sort of thinking about how you're going to make it work, and continually asking yourself the same critical questions that someone else will ultimately ask of you when you submit it for review. But working on local site trials, or even as a site PI for a multi-center trial, I think is very valuable.
Yeah, this is Sarah. I think I finally changed my name on here. I'm not sure why I was Meg at some point, but in any case, my background was I did my fellowship at NIH and at NINDS in the Human Motor Control section, and so I had quite a bit of experience in terms of investigator-initiated clinical research. But most of what my focus was understanding inhibitory motor circuits in the brain, and of course, it was clinical research, but at a more basic level, because we really didn't know what our therapeutic targets might be. And so when I had done that pilot trial, it was quite exciting that we actually had a potential therapeutic target. And although I had had formal clinical research training through the intramural program, as well as lots of experience doing that, I don't think I had the same vocabulary that Andy started out with, that doing a clinical trial, interventional clinical trial, definitely had different aspects than writing a protocol for an investigator-initiated clinical research project looking at an inhibitory circuit, for instance. So for me, it was really invaluable to gain that vocabulary, as well as to understand all the aspects I needed to think about in addition to typical clinical research concerns. So I had that background coming in, and certainly I've now participated in multiple clinical trials as a site PI, but that was a really wonderful transition for me. Really identified it as a gap in my training and in my tool belt.
Yeah, I don't have too much to add. I totally agree with what Andy and Sarah were saying. I also participated in trials as a fellow at UCSF. We were expected to be pretty active in helping to enroll patients. And I thought that was very helpful, just to kind of get a firsthand view of what the reality of a trial is. And then also when I got to Cornell, we were trying to run the POINT trial and some other, SHINE, some other trials initially. So I thought that was very helpful. So if you can get involved, I do think it will help you a lot. And I guess the only other thought I have is that, just doing research in general will help you with trials. You'll if you're doing observational work, you'll understand the importance of, measuring things accurately, classifying things accurately, the importance of you're picking the right population sample. So I think there's a lot of things you can do before you do your own first clinical trial that can help you prepare.
And and I'll just add to that I think some of it comes from progressing from your sort of unknown unknowns to known unknowns in areas where you need to potentially have some growth. When I started as a fellow, I was working on an epidemiology project, so I was getting a sense of research. I was doing a master's in clinical research, and I was participating as like a site investigator on the TNK trial, which gave you this sort of upfront, like at the patient level, what is it to do a research trial? But then from there, how I would have set up a research trial was one of the projects in graduate school, and we've used it as an example in certain parts of the course. I did manage to design a clinical trial that was really, really cool, but was impossible to enroll in graduate school. So getting teamed up with our experienced nurse coordinator at Michigan in terms of rolling out how our site would participate in the Clearer trial, a multi-center trial where you're basically handed a protocol, but being handed a protocol doesn't mean you're going to figure out how to get drug into somebody within 20 minutes of them hitting the door of the emergency department. And that requires a lot of planning and thinking that's even sort of different from what you were sort of doing in the enrolling investigator type situation. And those experiences can be quite valuable. So I think, again, you do also have to think about how you can value your time and how you can not be too overburdened with other responsibilities. And sometimes it's hard to know in advance whether it's going to be a good experience that you're going to learn from. But I do think the overarching idea that if it's a study that that your site can really succeed at, or you have a pretty good chance of succeeding at, taking a role as a local PI can help you design better trials too, and better research, better other clinical research studies, even if they don't involve an intervention. So I think I would encourage you, but particularly you just have to make sure you have the right other resources. If I had tried to tackle the Clearer trial at Michigan, but I didn't have the ability to tap into some experienced coordinators, my main coordinator was experienced, but not as experienced as a senior one we could ask a lot of questions of. That really helped in terms of the nuts and bolts of things. So the degree to which you can have exposure within your department to other research personnel, program managers, data managers, research assistants or associates who have enrolled in trials, I think you can learn a lot from those folks too. And that's something that I think is sometimes underappreciated, the amount of mentorship you can get from everybody else who's involved in the clinical research enterprise, because I've learned a ton from those folks, and just being in a position where you have the right access to those folks. And again, it's a matter of time, respecting other people's time. They're giving you some time to help you think through things. Something we tried to introduce, we've introduced in the course in terms of meetings with Dixie, Marianne, Valerie from the University of Michigan, and others. But yeah, I think that's a pretty, we've got a pretty comprehensive answer to Mehul here.
And Will, can I just add to that about the access to clinical research coordinator support, particularly for junior folks? If you're starting out with your first appointment, or you're at a junior level and you're trying to figure out how can I be successful, I always feel like I'm reminding folks that part of a quote unquote startup package for a traditional basic science investigator is to have laboratory support and resources and so forth. And if you're going to do clinical trials or clinical research as a junior person, you really should be asking for at least some percent effort of a clinical research coordinator who can help you be a site PI or a local PI for a study. And as Will said, you can learn from them as much as you can from any of your physician investigator colleagues. So really, that's something I did not appreciate as much early on, was the importance of having access to some effort of a clinical research coordinator, even before you get your own funding to support such a person.
And thinking creatively, like even if the person you may have a lot of effort on doesn't have as much experience, if you're like say at a StrokeNet site and there's a more experienced, sort of senior research project manager there, connecting them so that the person who's working more directly for you can get some sort of insights and feedback from the other people, the other research professionals in your department that can really help them grow too, because because sometimes you're in a position, I once had to be our local coordinator for the Shine trial at Michigan, and I would say I got about a C plus. I got us retrained. I didn't miss any outcome measures, but that's not I think a lot of times as physician scientists, we are expected to know everything and be great at everything, but the amount of training and other specific expertise that the research professionals bring to the table is different and very complementary. And that was when I moved past the unknown unknown to the known unknowns. I know how to be compliant with a lot of things, but I also know how much time and care that they spend on those, the attention to detail in terms of making sure you're regulatory compliant. And I was just very grateful that we had great people in place to do that once we hired somebody else in, and I didn't have to be our primary study coordinator anymore. It was just it was a stopgap solution, but we were able to move past it. Well, I think with that, unless anybody else had any other questions or thoughts, I think we could probably give you the gift of time, maybe read an article in the next 8 minutes if you don't have anything else on your calendar.
So I'd just like to thank our presenters today. Thank you so much for taking the time to share your experiences with us. Also, if everyone could just go to the chat box, the link to evaluate this webinar is there. If you could just give us your thoughts on that. Make sure you do that. And then just to remind you, we have 2 more webinars coming up, one on October 29th on pragmatic trials, and the last one on November 5th on common data elements. So thank you everyone for joining today, and have a good day.
Thanks everyone.
Take care, everybody. Thanks, Will. Thanks, Joy.
Thank you.